Hi, my name is Pedro Braga, and I'm a second-year medical student at Oklahoma State University College of Osteopathic Medicine at the Cherokee Nation. We did our research over unmet pediatric mental health care needs. Studies have shown that 1 in 5 children experience a mental health disorder each year, and that 2 in 5 children will experience a mental health disorder by the age of 18. The increasing prevalence of pediatric mental health disorders is concerning because mental health disorders can hinder children from adequately developing psychological, cognitive, physical, and emotional characteristics essential for a healthy transition into adulthood. There are a variety of factors that can be assessed to measure mental health. We decided to focus on mental health need. To measure unmet mental health care need, we used the National Survey of Children's Health, which is a nationally representative survey of children 0 to 17 completed by parents or primary caregivers each year for one child in the home. It's important to note that the age 0 to 2 years was not included in the denominator and therefore excluded from our analysis following National Survey of Children's Health guidelines. The survey question we used was, during the past 12 months, has this child received any treatment or counseling from a mental health professional? A need was defined as if they answered yes or no, but this child needed to see a mental health professional, and an unmet need was defined as if they answered no, but this child needed to see a mental health professional. First, we determined population estimates and plotted the trends for unmet mental health care needs among children from 2016 to 2020 for all children and by age, race, ethnicity, and percent of federal poverty guideline. Next, we used a design-based chi-square test to determine if there was a significant difference in the rate of unmet mental health care between 2016-2019, representing pre-COVID, and 2019 to 2020, representing the onset of the COVID-19 pandemic. Next, we estimated state-level rates in unmet mental health care needs and determined the 5-year average for each state, as well as the percent change from pre-COVID and onset of COVID-19 pandemic. Last, to assess for disparities, we constructed logistic regression models to measure associations via odds ratio between children, unmet mental health care needs, and demographic factors. For each demographic factor, the group that had the most responses served as a reference group. Overall, there was no significant improvement in the number of children with unmet mental health care needs over the 5-year span, despite declining mental health with increased mental health disorders as well as increased funding for mental health care from the COVID-19 pandemic. First, I want to draw your attention to this blue line here at the bottom representing white children and compare it to this red line at the top representing black children. We found that black children showed the highest rates of unmet mental health care needs, nearly double that of white children. Next, I want to draw your attention to this yellow line that represents American Indian and Alaska Native children. Following National Survey of Children's Health recommendations, groups with less than 30 observations are not applicable to statistical analysis, so American Indian and Alaska Native children were excluded in 2017. From our logistic regression model, where white children were our reference, black children were 4.7 times more likely to have unmet mental health care needs compared to white children, demonstrating the greatest health gaps compared to other groups of children. And also, black children had the highest unmet mental health care needs each year, with an average of 30% having an unmet need. Possible contributors to these barriers could be the role of systemic racism, intergenerational trauma, discrimination, daily microaggressions, and the role of stigma in the mental health care seeking process. Looking at unmet mental health care needs by age group, we recoded the age groups 3 to 5, 6 to 10, 11 to 14, and 15 to 17, and our reference group was 6 to 10. As you can see, that children in the 3 to 5 age group in pink consistently had the highest rates of unmet mental health care need. From our logistic regression, we found that children 3 to 5 were 2.6 times more likely to have an unmet mental health care need compared to children 6 to 10 years. And also, children 3 to 5 had the highest unmet mental health care needs each year, with an average of 32% having an unmet need. Possible contributors are likely related to family circumstance and developmental attributes of the child. We also looked at urbanicity, and according to the National Survey of Children's Health, urbanicity was defined as metro and non-metro. We found no statistically significant difference among children living in metro areas compared to non-metro areas. To assess income, we used the National We used the percent of federal poverty guidelines. We designated the 400+% poverty level as our reference group, and we found that each decreasing percentage, there was a statistically significant increased likelihood of having an unmet mental health care need. Looking at this map on the left represents the percent change among states from 2016 to 2019, and the map on the right represents the percent change among states from 2019 to 2020. A couple things I'd like to point out is that Nevada displayed an increase in unmet mental health care needs going from 2016 to 2019 to 2019 to 2020, and Kentucky showed a decrease in unmet mental health care needs. Possible contributors could be the mental health provider shortage in Nevada and Kentucky passing legislation aimed at reducing the mental health provider shortage. Limitations include the fact that this was parent-reported data, which excludes children where the caregiver was unaware of the mental health care need, and also children living in group homes were not included in the data. A significant limitation was the suppression of racial ethnic data, as previously mentioned groups with too few observations were excluded or aggregated into other and were not controlled independently. This was the case for American Indian and Alaska Native, multiracial, and Native Hawaii and other Pacific Islander. This is significant in particular given the data showing American Indian and Alaska Native having the highest suicide rate of any ethnic racial group. Efforts to improve mental health surveillance are needed. Other limitations include physical, such as lack of transportation or accessibility to provider, cultural limitations, lack of knowledge and understanding the healthcare seeking process, and lack of insurance in the role of socioeconomic status. Future directions to reducing these disparities include improving access through expansion of telehealth, policymakers, educators, and healthcare providers advocating for evidence-based programs, and funding and improving surveillance measures, especially for minority and low-income groups. And these are our references. Thank you.